Dr. Amit Thapa, using intraoperative neuromonitoring IONM effectively for safe spine surgery.
Thank you, respected chairpersons and dear friends. Today I bring to you a different topic. Since morning we have been listening to various techniques of UB and endoscopic surgeries, but as spine surgeons we all have been using intraoperative neuromonitoring, so I'm trying to discuss on things which we found in my institution as well as in all of the places where I worked. This thing works very well, and that's how we want to do it. So there's nothing commercial related to this presentation, and it's purely education and sharing experiences. Uh, this is beyond any disagreement that the intraoperative neuromonitoring, or IONM as we say it, is a useful modality in neurosurgery to ensure patient safety. However, what has happened over the years is as the surgeons, we keep on so much engrossed in the surgery, and we do too much think our anatomical prowess is so good that sometimes we just ignore the INM calls. It is just like a husband ignoring the wife's calls. So why not to make the wife's call much more genuine? And that's how we wanted to make it better, because what we have found that's both the high false positive and false negatives, the results actually negates its benefit. So if in case we can mitigate the errors, and the most common errors which have been seen by most of the stakeholders is lack of communication between the technician, the person who's interpreting that, anesthesiologist and the surgeons. These are the four different stakeholders working with the INM. And that's why this error or lack of communication has actually got magnified whenever we're talking about the positives and the negatives in the INM findings. Now this has become much more extreme because of the rampant use of telemonitoring, particularly in this field. I've been hearing that in US there are certain centers who are actually covering whole of the eastern coast, whole of the western coast for all these IONM studies, which is very much difficult to understand, because the communication is something which is almost lacking when we are doing a telemonitoring system. So what we have introduced is a mandatory protocol where all these stakeholders should communicate before the surgery, during the surgery, and even after the surgery. And what we found was the initial problem with implementation, but however, when we actually adopt this protocol and try to use it in each and every case thoroughly, then it becomes very easy. It is just like a WHO surgical checklist which we follow in every patient. So this is how it looks like. I will just describe it in detail, and this is how it appears in our OR. So you can see the INM setup and at extreme top of the patient as we are preparing the patient for the surgery. So I'm dividing it into two lists. So this neuromonitoring alert response checklist actually starts with the name of the surgery and what all INM modalities we have put on the patients. Every INM event is being marked either as a focal or asymmetric event, which can tell us that it may be a root or a caudal cord injury, or it may be symmetrical changes which may be because of the anesthetic or hypoperfusion. And whenever these alert signals comes, the surgical pause has to be attended. So we have to stop the case, and then we have to attend to each of these signals, and then every senior, either from the anesthetist, from the neurophysiologist side, as well as from the neurosurgeon, and the in-charge nurse has to come inside the theater and see what's happening. So now individually, each of these people will do the job simultaneously. So the neurophysiologist will try to reduce the noise and the electrical interferences. He will do a trial of the INM testing, starting with the increasing of the current, as well as check the electrodes and connections, check the impedance of the stimulating and the recording electrodes, optimize the stimulating parameters, and also assess the patterns and the timing of changes. The anesthesiologist, what does he do? He actually does check whether that was the last bolus of the anesthesia drugs or the muscle relaxant given, check for the train of four impulses, whether they are there or not, particularly when the dip in the electromyographic signals are there, and check the neck and the limb positions, because sometimes compression can also lead to decrease in the impulses. And then check the depth of the anesthesia and look at the various vitals like blood pressure, respiratory rate, heart rate, and the BIS indexes. The BIS has to be lowered to 40 and reduced. Usually in these types of anesthesia, we do not use inhalation anesthesia, but if in case it is being used, then reduce the MAC to 1/3, and stop inhalation agents like desflurane. IV anesthetic, if in case given like a propofol, the dose has to be reduced. Add the adjuvant drugs like ketamine, increase the MAP. Now this is the first tier regimen. So in the first tier regimen, what we do is we increase the MAP from 70 to 90 milliliter mercury at least. And then we want to optimize the partial pressure of oxygen and carbon dioxide and maintain the pH values by doing the ABGs. And then we want to maintain the hemoglobin. The patient may have bled too much during the corpectomy or other procedures, so that has to be checked. So the hematocrit in these particular things should be kept around 30% and above. And then we want to maintain the normothermia and normoglycemia. Then the neurosurgeons, they're also doing the same thing simultaneously. So what they're doing is they stop the current manipulation. We do not reverse it now. We just stop the current manipulation. We evaluate any maneuvers which had just preceded the IONM alert. If in case we are putting some tractions, the tractions has to be avoided, to be removed. And particularly when we are doing some intradural stuff, if we are putting some cottonoids over the dura, that has to be taken off, because these types of cottonoid or even application of wax or even like sometime putting a sponge stand or a gel foam as we call it can also cause cord compression. So these things has to be taken into consideration. And then we have to look for any implant malposition by doing an x-rays. If in case the signal do not come by, then we can even reverse the corrective maneuvers or any rod removal if in case we have put that, particularly when we are doing spinal deformity cases. The blood loss is something which we all should be cognizant about, because sometimes as the surgeon we keep on going on for a long surgeries and we forget it. And keep the warm saline on. Sometimes hypothermia can also induce it, so flush that area with the warm saline. And then we can give papaverine if in case the patient has some sort of a vasospasm. So local installation of papaverine with the papaverine dipped cottonoid is very helpful. And then we can arrange for a perioperative imaging. If in case the recovery of IONM signal occurs by then we make a note of it, and then we also put a note of it as to how much time did it take for this reversal to occur. And then what was the signal after this intervention. If there is no improvement, then we go for the Tier 2 regimen, that we increase the MAP to more than 100 millimeter mercury, use the neuroprotective strategies like IV methylprednisolone or pharmacological burst separation, that is for intracranial surgeries, and then give calcium channel blockers. And then if in case nothing is working by then we should always call the second team or the second surgeons who can always assist in these types of decision making, because this is a difficult situation where we have end up having created a sort of a injury in the patient. So that's why it's always better to ask for another spine surgeon, another neurosurgeon to be there in this particular area, where they can also suggest as something which we have missed during this whole plan out. And subsequently we can plan for a wake-up test or a body presence surgery. And after we do that, we actually go for the identification of any recovery during the IONM signals and quantify how much signal recovery has occurred. And such patients, whenever we are transferring to the post-op, the post-op team has to be counseled regarding what we have found and what are the prospected plan of management in the later period, and the nature of the post-operative deficits the patient wakes up. And these things has to be signed by each 4 of these stakeholders, from IONM provider, neurosurgeons, anesthesiologists, and the nurse in charge who is assisting us, so as we can legally also we can quantify as to what we have done during this particular sort of problem. Now, with this particular thing in mind and also training the whole team, we started implementing this particular project in a hospital almost 2 years back. So this was a 6-month study as to how this whole thing works up in our hospital. And we have actually done with various types of IONM modalities in this particular study, and also we have trained our staff in that. So anesthetic protocol we have tried to maintain standardize in the whole operations where we used IONM. So this is a set of things which we all know as to how the things work. So in a total 77 patients where the IONM studies were used in a protocol-based manner, which was across all the age groups, as you can see here, we have done in both elective and emergency cases. So these are the different layouts of how IONM studies were used in these cases. We found that there were 26 alarms during this particular procedure as compared to 51. There were no alarms, but in none of the patients who had the alarm had a post-operative deficits. And all the patients could have the alarm averted or reversed after the first tier management itself. So we found that the maximum amount of positive alarms was actually raised during the pedicle screw placement. However, they was all managed in the first tier management itself. So this is nothing new as such, because this protocol had been suggested way earlier in 2020, and also in various other algorithms was suggested, and they have found that this is a very good technique if in case it is well versed with all the teams, and the team members should actually communicate. So what is the most important thing is the communication between the neurosurgeons, the anesthesiologist, the person who was doing this IONM studies. So if in case all the people are talking to each other, this protocol-based IONM is possible. And of course, this is one of the most important thing which can be done in the spine care. So to conclude, this protocol-based INM should be implemented. That is our philosophy in the spine surgeries these days, which has been found to have the best results, which actually minimizes the risk of the true positive as well as the false negative findings, leads to the high sensitivity and specificity, and allows for the patient safety during the spine procedures. So thank you once again for your patience listening, and I'm happy to invite you all. From November 14 to 16, we have a national conference in Nepal. This is in the eastern part of Nepal called Chitwan. So it's a lovely place full of wildlife. Thank you once again.
Thank you, Dr. Amit. Very nice presentation, very good protocol. Do you use in all cases of spine or only intradural pathologies?
Well, it depends upon whether we are expecting any dip in the IONM findings. So if in case, say for example, the patient is having a sort of a corrective maneuvers to be done, then definitely we will place an IONM. However, we are restricting, or rather we are using much more frequently in an intradural pathologies.
Now, when you are doing a tumor excision, say intramedullary, and you are, while excising, you find there is a drop in the levels. When the technician tells you that there is a drop, do you stop for
Yes,
some
of
time?
course. Yeah.
And you continue after some time? Suppose it does not improve, then what do you do?
So as per the protocol, we have to stop it, and we have to stop and follow all the first IR regimen, so that we have to have a reversal of the signals. If we do not get the reversal of the signal, then we go for the tier 2 regimen. And even if the tier 2 regimen does not fail to show the recovery, then we have to stop the case because the patient has already developed the deficits. So if in case we had already prepared pre-operatively that if the patient do have some amount of deficits, but it's okay with the patient, but we can go with the surgery, then of course we can go ahead. But in most of the cases, patients are very much concerned about any deficit. So if in case that happens, then we definitely like to stop, or particularly stop in that area where the deficit has occurred. We can carry on with the other area in the intradural pathologies.
We have seen, we have done the tumor excision, we are going ahead and there is a drop. It does not improve. Now you stop the surgery. You reverse the patient, you come out after the closure and patient doesn't have a deficit.
That's good for the patient.
Yeah, good for the patient, but is it not a fallacy?
Yeah,
that's we have found many times this is happening. So it is not always possible you follow this strict protocol. If this is not there, it's very difficult at the time of surgery to decide whether to stop further, to operate further, or to stop completely.
So this is why this protocol helps here, because what we have found that most often, just because of the blood clots itself, just because of the hypothermia, hypoglycemia, there are so many reasons which the whole team has not worked upon to look at, and that's why we are finding a false positive signals.
Exactly.
So the false positive is the biggest problem, because once a false positive signals appears, the surgeons are all afraid, so they will stop it. And we end up stopping the case which was supposed to be completed.
Yes, that is what happens in many times. And one has to be, take a decision on table whether should we go ahead or should we leave it behind. In certain cases, when we were doing intramedullary tumor, trying to excise the tumor, we found a drop, did not improve. I don't know, instinct said, okay, you go ahead and do it. We removed it and patient improved. Patient had no deficit post-op. So this is another fallacy which we come across many times.
Yes, you are right. So that's why following this protocol actually does just not addresses to most of the things, yes, which can actually give you a false positive, or even that, for that matter, false negative reports, but also can also make you legally safe. For one reason, because all the 4 stakeholders have done their best to revert the signals, and they have found it. So there is anything ignorant of all of these stakeholders. They have not taken into consideration while addressing this issue. So I think this particular protocol should be followed in every center where people are doing aggressive work, where the chances of neurological deficits is much more higher. So as not only to document what they have done, but also to give the patient the best chances of recovery after the surgery.
Yes. As a neurosurgeon, we find maximum problem is facial nerve when we are doing an acoustic. Many a times they say there is no signal, and patient wakes up with a facial nerve pulse.
That's true.
Correct. Thank you. Nice.